Welcome back, Richard. May 1st. It is May 1st, my
Welcome
friend.
to May.
And we are going to touch on a topic today straight out of the headlines.
Yeah, we often talk about psychology in the news. We have a hot one today.
We do, and it's not even, we don't do a lot of pop culture type stuff on our program, but we are going to kind of touch on some pop culture stuff today, because we're going to talk a little bit, at least at the beginning of the podcast, we're going to talk a little bit about the big trial, the defamation trial of Johnny Depp and his now ex-wife, right?
Yes, yeah, they were divorced. They were married in 2015 and divorced in, I think, 2016. It was a 15-month marriage.
Yeah, Johnny Depp and Amber Heard. And it's really been a huge in the news because of the stories that have been told about what has happened between the two of them, what he had allegedly done to her and what she has allegedly done to him. Right. And so we thought we would talk a little bit about this because it leads into some really important psychological things that we should review and kind of talk about again.
Right. Yeah, because the headlines are Amber Heard has been diagnosed with these two personality disorders, and that's hit the news. And I thought, well, let's take a closer look at that. And so it stems from this trial, the defamation lawsuit, which you mentioned. And there's some serious money. There's some serious money here at stake.
Right.
Johnny Depp is suing her for $50 million,
right?
Because alleging that, and what he's saying is that she wrote an article in December in the Washington Post in December of 2019, alleging abuse. And though he wasn't named in the article, it was obvious who she was talking about. So and as a result of that article, he was taken off the cast of Pirates of the Caribbean, right. And in doing so, lost a considerable amount of income. That was a big franchise for him. So he's saying, you cost me, your allegations, which his attorneys are saying are false, cost me this money. And this has been tried once in the United Kingdom. There was Johnny Depp sued the Sun, a publication in England, over the same issue. But this is because the laws are different in the UK and in the US, and because Amber Heard was not named in the UK lawsuit, the judge said that this trial could proceed in the United States. Johnny Depp is suing her for $50 million. She is countersuing him for $100 million for saying that she was defamed because his legal team referred to her claims as false and that this is all a big hoax. And so when I say serious money, that's some pretty serious money. I mean,
yeah. So, and all of this is following their divorce from like 2015 or something. Right. So it's this is ongoing. And but how this kind of ties back to the topic that we talked about on our podcast is that Johnny Depp's legal team hired a forensic and clinical psychologist, Shannon Curry, right. And she did an evaluation of Amber Heard, mm-hmm. and in that evaluation, diagnosed her with borderline personality disorder and histrionic personality disorder.
Right. And my understanding is that she spent 2 8-hour sessions with her.
Right.
So she was with Amber Heard for a total of more than 16 hours.
Right. Yeah, that's what we have found in the reports. So that is much more time than most of us would ever have in a couple of settings, in a couple of visits, meeting with someone. We might have that amount of time over, a year, maybe, right. Right. Maybe 6 months or so, but over a couple of visits, that's a tremendous amount of time. and again, made those diagnoses. And so, as you said at the beginning of the podcast, the headlines are saying that, Amber Heard is diagnosed with borderline personality disorder and histrionic personality disorder. And so we thought that it would be important to kind of review. We've talked about personality disorders in the past, but it's been a little while. And so we should talk a little bit about that. And especially those two, because those are two heavy hitters when it comes to personality disorders.
Those are two very serious diagnoses. I mean, and she seems to have been very thorough, at least in the amount of time that she took. It seems to be a very thorough, thoughtful diagnostic workup. And she ended up with these two diagnoses. So what does this mean? And so we thought, well, let's talk about the personality disorders. To talk about the disorders, you have to first of all talk about what personality is. What do we mean by personality? Absolutely. And essentially what we're talking about is when we say it's a unique way of thinking, feeling, and behaving. Personality is what separates us from others. It separates us from other species. We have certain characteristics as a species, but it also separates us from each other. What differentiates us from each other is how we think, feel, and behave. And that's what we call personality.
Right. Yeah, absolutely. And, we do see that in other species, because you can see, dogs have a particular, temperament and everything. And temperament is an important word to use, because that is sort of, we've talked often about nature versus nurture, right? And this debate on, are you who you are because of your biology, or are you who you are because of how you were raised and your experiences? And personality is this wonderful combination of both, because we're all born with a temperament, and that's sort of a biological piece of it. And those of you who have children, you see some of those temperamental things from the very beginning, very early on, and that sort of sets the stage. And then life experiences kind of guide you and lead you to going in different directions based upon that. And so, it's the way that you see and interpret and interact with your world, the thinking, feeling, and behaving, and it's influenced by different things sometimes, but we typically think that, once a person gets through adolescence and into adulthood, your personality becomes pretty stable. Some things that we can do early on in childhood, and during, Freud had that, in his psychosexual stages of development, there was that latency period where it was like, this is sort of the last ditch hope during this day. Those middle adolescent years, this is your last ditch hope to make any substantive changes to what your personality is going to be, because once you get through that, it's pretty stable over time.
And you make an important point there, in that we typically don't make these diagnoses in children and teens for that reason. That there's still some changing that could occur. And many teenagers look like they have personality disorders, but it's just normal teenage behavior. It's not pathological.
Right. Yeah. It always makes me just shake my head and cringe a little bit when, a person comes in and they're 9 years old and they have a diagnosis of a personality disorder. And it's like,
or even the teenagers that we see, particularly in detention centers, many of them end up with a personality disorder. It's a diagnosis that probably should be reserved for adults, except in very rare instances. So that's what personality is: stable over time, and it talks about our character. So what is a personality disorder? Well, if personality is about thinking, feeling, and behaving, then a personality disorder is thinking, feeling, and behaving that deviates from cultural expectations. And that's a really important point. Different cultures have different expectations. And so what is deviant in our culture might not be deviant in another culture. So we're talking about thinking, feeling, and behaving that deviates from cultural expectations. And also, and this is important, that causes distress or functional impairment. As a DSM diagnosis, we have to find out where the impairment is. We have to acknowledge, we have to establish that there's either distress or impairment. Distress would cause impairment, but there has to be some functional impairment.
Right. Yeah. And the newest edition of the DSM-5, kind of shifts personality disorders just a little bit in the way that we have thought about it, because it changes the multi-axial system of diagnoses. And so that's beyond the scope of this podcast today. But there's four. What the DSM has done is it's kind of categorized the different personality disorders into four classes or clusters. The first cluster is, includes behaviors and characteristics that are deal with thoughts. And so the thoughts are very rigid and extreme and distorted thinking patterns and things like that. And so there's a group of diagnoses in that category that focuses on those thoughts. The second,
go ahead. Sorry.
Oh no, sorry. The second is it focuses more on feelings, and it's the problematic emotional system, emotional responses to things, and we call those, and I'm calling them 1, 2, and 3, and 4, but it's cluster A, cluster B, cluster C, and cluster D. And so this is cluster B. And cluster B, this is where, again, a lot of those emotional responses to things, this is where those fall. Cluster C is going to be impulse control things. And again, we're talking more than just like ADHD. We're talking about sort of a pervasive pattern that's rooted in personality and rooted in the way that the way that they see the world and interact with the world. And then the final ones are significant interpersonal problems.
Right.
So those are, so when we think about these four, and I think I was trying to categorize those into the clusters. These are the four areas that, when we think about personality disorders, these are the four areas that are affected. Again, thoughts, feelings, behaviors. They roughly fall into some of these different clusters, some of the different clusters from the DSM. But when we talk about personality disorders, these are the four areas, these are the four ways that we see personality negatively affected to the point of a personality disorder.
That's right. So we think about these four areas of how we think, how we respond emotionally, how we relate to others, and if we can control our own behavior.
Right.
Okay, so those are the kind of the four broad areas that we look at with personality disorders. Okay. Right. And so what DSM does is there are 10 personality disorders. And as you say, they're in 3 clusters. Okay. Right. So cluster A.
Yeah. Cluster A is, I was talking about thoughts and things like that before. And cluster A is, very characterized by odd or eccentric or awkward, just social problems, eccentric thoughts and beliefs. And so in this cluster, we have diagnoses like paranoid personality disorder, right. What's called schizoid and schizotypal personality disorders. And so those are the 3: paranoid, schizoid, and schizotypal. And all of these are characterized by bizarre, delusional, sometimes beliefs. And it's sometimes people have a hard time appreciating the difference between these, like a paranoid personality disorder, from the paranoia that we see in schizophrenia, for example. Right. Remember that we talked about personality as being stable over time, right? And so with schizophrenia, you have episodes, you have psychotic episodes. And so you may be very paranoid during this episode. With a paranoid personality disorder, it's stable over time. So it's like that all the time. It doesn't go away. It doesn't fade and kind of come in and go out. Right. It's there all the time.
That's right. And these are these odd, eccentric behaviors. Usually they're most apparent in social awkwardness and social withdrawal, but they're not the kind of psychotic disorders that we talk about with schizophrenia. Schizophrenia is a total it's a total break with reality. We're not talking about that. We're talking about personality characteristics in people who are still functioning in the real world, but right. That's just very odd and eccentric behaviors.
Yeah, and the schizoid and schizotypal personality disorders are fascinating because you do see a lot of social withdrawal with those. Again, as you said, they may be involved in the world around them, but they don't develop close relationships. It's not
Right.
it's not
Right.
like autism spectrum where they seem to lack an awareness of that. It's just that they don't trust other people, and they may have sort of fantastical beliefs, and so they may be really into like horoscopes or different belief systems that that may seem, as you said, sort of culturally unaccepted beliefs that are very eccentric and very extreme.
Yeah, I had a young teenager come in one time and say, well, I can do Jedi mind tricks. It was just when Star Wars first came out, and they were talking about Jedi mind tricks, and this young man said, I can do that. I can sit in my classroom and I can control what other people are thinking. And that's sort of this odd, eccentric belief in what you can do.
Right.
And then there's cluster B. Now, cluster B is probably the most well-known, the most talked about of the three clusters. And it was Amber Heard was diagnosed with 2 of the cluster B personality disorders, borderline and histrionic. These are known mostly for the dramatic and highly emotional behaviors and thinking. And I'm going to let you walk through. You explained cluster A, which is these kind of odd relationships with other people. What about cluster B?
Cluster B is also has some difficult social aspects to it. But the 4 of the diagnoses in cluster B are borderline personality disorder, narcissistic personality disorder, histrionic personality disorder, and antisocial personality disorder. Right. Now, something we're going to talk about later is that, these 2 of these diagnoses, borderline and histrionic, are very commonly diagnosed in women. The other 2, narcissistic and antisocial, are very often diagnosed in men. Right. And so there are those traits. And so as we'll talk about in a few minutes, that raises some controversy at times. But when you're thinking about these disorders, we're talking about, as you said, dramatic, emotional, erratic, poorly, you can't predict what's going to happen, especially with borderline personality disorder, because it's sort of this combination of narcissism and emotional dysregulation, and it's oftentimes misdiagnosed for borderline is often misdiagnosed for bipolar disorder, because that same type of erratic. A lot of times you will see it's characterized by this push and pull when it comes to relationships, and there's a lot of self-harming that's associated with borderline. So it's a very it's probably arguably one of the most difficult diagnoses altogether, one of the most difficult diagnoses to work with and to manage behaviorally or medicinally or in any way clinically.
Right. Yeah, one of the things that we typically associate with borderline is these very intense relationships. They're intensely positive and then very quickly become intensely negative. I think one of my daughters would call it from goat to woat. You're the best thing that's ever happened to me. And within a week or two, or a day or two, you're the worst person I've ever met. And so there's this fluctuating, erratic relationship issues that arise with people with borderline personality disorder. It's the intensity and the erratic nature that really defines what a borderline personality disorder is.
Absolutely. I once worked with with a person with borderline personality, and she quite literally met a person on a Saturday night at a party that she had never met before, met him on a Saturday night, and the following weekend, they got married. Right. So it's one of those, everything is thrown in, and like the person wasn't even a US citizen, was over here just visiting family, and they got married and all of it. So it's that kind of jumping in, certainly there's some questions about him being willing to do that as well. But that's what you sometimes see with borderline personality disorder. Narcissistic, this one also is pretty difficult for a lot of people, because a lot of people have narcissism. Let's just be honest. And to be, if we work to be very critical of the term narcissism, anyone who is a business owner, anyone who any physician, any doctor, any psychologist, there has to be some level of narcissism built into them, because I want you to come to me because I'm going to help you feel better. I'm going to help you resolve these issues. That means that I am able to do something that other people may not be able to do. And there's a sense of elevated esteem that has to come with that. That is very different than narcissistic personality disorder. Narcissistic personality disorder is, I am the best. And people only do things because I'm allowing them to do things, and I'm telling them what they need to do. It's a very different level of control and sense of their person that much more so than what we see in a person who just is very confident and is forward that way, assertive.
Yeah, and then you have the other one that's typically associated with women is histrionic, and we're going to talk in detail a little bit later about histrionic personality disorder, because that's one of the diagnoses that was made with Amber Heard, and so we want to sort of expand on that a little bit and explain, because it's less well known. It's not talked about as much, less well known.
Absolutely. And so the final one is antisocial, and there's a difference between, people use the word antisocial quite often, and I'm finding more teenagers using the term antisocial. But when they're using it, they don't mean antisocial, they mean asocial, like they don't want to interact with other people, and so the absence of social is asocial. Antisocial is sort of it's sort of like the adult version of a conduct disorder. So these people are out with the intent to violate the rights of others. They are they don't mind harming others. They don't have a sense of regret, really. They don't have a sense of remorse when it comes to what they've done to other people or how they may have harmed other people. And so many times you'll see people who have extensive criminal histories and things like that. Oftentimes they will be diagnosed with antisocial personality disorder because they do these things, they harm other people physically or in other ways, and they seem to have no remorse, or they don't feel bad about it in any way.
Yeah, and as you said, many people in prison are there because they have antisocial traits, antisocial behaviors. They hurt other people, they steal from other people, they take things that don't belong to them, and those are antisocial personality traits. And then cluster C is what we call the anxious and fearful cluster.
And this one also has three. It's the avoidant personality disorder, dependent personality disorder, and the obsessive compulsive personality disorder. And again, they're not as commonly diagnosed, but with these, there's a social aspect to like the avoidant personality disorder, because they're kind of avoiding relationships, but they also avoid decision making, and they avoid taking steps to do things that they need to do, which is closely tied to the dependent personality disorder, where it's this is where you find those people who again, they don't make any decisions. They need someone else to make the decision for them. They need someone else there with them to do everything, much more so than a social anxiety or generalized anxiety disorder or something like that. This is, again, that pervasive all across the board need for somebody else to make decisions and guide them through some of these things in their life. Go ahead.
And the last is obsessive compulsive. And here again, we have to be careful, because there's obsessive compulsive disorder and there's obsessive compulsive personality disorder. They're distinct. They're related, but they're distinct.
Right. Absolutely. And usually we did a podcast, man, I don't even remember how long ago, but this just popped in my head because that's one of the differences between that obsessive compulsive personality disorder and obsessive compulsive disorder is awareness. There's this idea that with obsessive compulsive disorder, the person knows that they have these obsessions and compulsions, and they're many times they're distressed by them, they're frustrated by them, and they know how much time of their life is taken up by these obsessions and compulsions. With obsessive compulsive personality disorder, they're not necessarily aware that they have these tendencies. And that's the thing with all of these personality disorders is that the people who have personality disorders aren't really aware that they have a personality disorder. They don't think that they see the world in any different way than anybody else.
Right.
Which is the case for all of our personalities, right?
Yeah.
Whether we have a personality disorder or not, the way that we see the world is the way that we kind of assume everybody else sees the world. Right. And so when somebody does something that's way out of your own character, you think, why in the world would someone do that? Well, their personality may sort of guide them into that direction, whereas your personality doesn't.
Right.
So when you have a personality disorder, they're part of the reason that they're so difficult to treat is because the person typically isn't aware that the person with borderline personality disorder that we're going to talk about next, that person isn't aware that, not at a decision level perspective, that they are doing these things.
It's who they are.
Right.
Who they are. It's most obvious with narcissistic personality disorder. Right. There's nothing wrong with me.
Right.
I think everybody's like I am. I'm just better than everybody, but everybody's just like me.
Right. It's the difference between, we talked before about in a podcast about ego dystonic versus ego syntonic.
Right.
And these folks are ego syntonic. They don't know. They just think this is everybody. Everybody thinks this way. Everybody sees the world this way.
Right.
Whereas when you talk about some of the other disorders like obsessive compulsive disorder or even schizophrenia to some extent, the person knows, no, I think differently. This is different than what is typical. This is different than what other people experience. And this is a problem.
Right. In fact, at the level of intervention, the first order of business when you're dealing with somebody with a personality disorder is to get them to acknowledge that there's a problem. Right. And that whether you're talking about cognitive behavioral therapy, dialectical behavioral therapy, most of us have heard about dialectical behavioral therapy. And the first step is to get the person to acknowledge that, yeah, this is becoming a problem for me, because initially they don't see it as a problem. This is just who I am. There's not really a problem here, but there is really a problem here. And that's the first step, is to get a person to acknowledge that there's distress or impairment.
Absolutely.
And then you can get on with therapy.
Definitely. So as you mentioned a few minutes ago, Amber Heard was diagnosed with 2 of the cluster B personality disorders. She was diagnosed with borderline personality disorder and histrionic. Right. And as we said, as we were going through them, borderline is one of the most significant, one of the most challenging and difficult diagnoses. Histrionic is a little bit less known, but also very challenging and very concerning if a person has that. But let's talk a little bit about personality, a little bit more about borderline personality disorder.
Right. Yeah. I guess the hallmark is fear of abandonment. Well, yeah. One of the important symptoms is fear of abandonment. There's this fear that people are going to leave you, and so you tend to develop these very unstable, very intense relationships to hang on to to make sure this person stays in your life. And yet the person engages in behaviors that pushes people out. There's an erratic behavior, erratic thought patterns that you're, on the one hand, trying to keep people close, and on the other hand, your behavior is pushing them away.
Right. And as soon as the person feels like the other person is going away, they will they may either finish the job and just push them out and get rid of them, like over, you made the wrong kind of coffee this morning, or it could be over something really small, but it suddenly means that it's quite literally to the person, it may mean feel like it's the end of the world. Or they will do something to try to pull them back. And so this is where you get into self-harm, and they may say, they may feel as though, if you leave me, I'm going to really hurt myself, or I may commit suicide, or something like that. And you get those kinds of what the other person may see as a threat. The person with borderline truly feels that way.
Right.
And they're really struggling with those experiences, and they truly mean it. And there's a significant risk of self-harm and suicide in this group of people. But again, as you said, it's those types of things that tends to push others away. It makes it difficult for them to maintain healthy relationships.
Right. And you mentioned the similarity between borderline personality disorder and bipolar disorder, because one of the characteristics, one of the symptoms of borderline personality disorder are these intense mood swings.
Right.
But they're usually mood swings in response to your relationships with other people. Right. You get, you begin to suspect that somebody doesn't like you anymore, or that they're working against you in some way. And then you have this these intense emotions that get expressed in inappropriate and intense anger, where that this is the love of my life, but then in the next, something changes, and all of a sudden it's you're the worst thing that's ever happened to me.
Right.
It's that intense shifting back and forth.
Absolutely. And I think that it's, I think that the vocabulary that the DSM uses is part of what creates such a problem with that, because it is referred to as a mood swing, but it's not the mood that's swinging. It's emotional ability. It's emotional irregularity and dysregulation that the person is experiencing. It's, this is where you get that everything is just fine, and then one thing is said, and all of a sudden, we're on this other end of the spectrum. But it's those emotions that swing, not necessarily the mood per se.
Right. And we also, with bipolar disorder, there's a pattern to it. There's a rhythm to it, where there's intense arousal and then depression. So with this, it changes rapidly, and you might have a few cycles a year. With bipolar disorder, you could have cycles every day. I mean, you could have this these intense mood swings with borderline.
You have that daily. Yeah, absolutely.
Right.
And again, just because you have emotional swings like that throughout the day doesn't necessarily mean you have borderline personality disorder. But it's one of those things that makes it difficult. And that's why we pointed out early on in the podcast today that, the psychologist that did the evaluation with Amber Heard met with her for a long time, 16 hours, you said. That's the type of time that's needed to really see some of these personality traits, and to make sure that it's not just, just not just something that's happening, or just something at that particular moment.
Yeah, because you have to make sure that it's not bipolar disorder, that it's not some other diagnosis, and so you need to be careful when you're making a differential diagnosis. It takes time to gather enough information to make a reasonable diagnostic decision.
Absolutely.
Because there's always overlap. That's one of the things we know about psychiatric and psychological or mental health disorder, is we know that there's symptom overlap. And so the clinician's task, responsibility, the obligation is to differentiate one from the other. Okay?
It's not easy.
No.
It takes time.
But so the second diagnosis she got was histrionic personality disorder.
Yeah. And this one is also unstable emotions, distorted self-image. You see a lot of anxiety, a lot of distress, a lot of intensity with this one as well. But it's also the other side of it is that, or what makes it a little bit different than borderline, is that you don't necessarily see it doesn't necessarily have to be relationship dependent. This is just sort of generally speaking, a histrionic person is has that heavy tendency leaning towards that unstable emotions and distorted self-image, and they can just, a lot of that can be brought upon by themselves.
Right. Yeah. With borderline personality disorder, it's these intense, erratic, unstable relationships. The relationship with other people. With histrionics, it's I want to be the center of attention.
Right.
I crave, and I will do what I need to do. I'll do anything I have to do to be the center of your life, or the center of attention for everybody. When they walk into a room, they want all the attention on them. When they're in a relationship, they want the other person to attend completely to them. We all do. We all want that.
Right.
But we don't have the intensity and the drive to seek it in all situations with all people.
Right. Right. So again, whereas the borderline is tending to respond to those, if those interactions and those relationships aren't going the way that they want them to go or need them to go, that's where you see the borderline traits. The histrionic traits begin with the person themselves. This is what I need. I need to be valued. And the way that they're valued is through the way that other people treat them and interact.
That's right. Yeah, they have no they don't have a strong ego.
Right.
And
where the anxiety all comes from.
Yeah, they don't have a strong sense of self-worth, and it all comes from other people telling them how wonderful they are. So they need justification, and they need to be validated by other people. But it's an intense need to be validated, and they will do everything they can to get that. And that's where they start to exceed cultural expectations. Is the behaviors that they engage in to get the attention that they crave.
Right. Yeah. So yeah, when you combine these two, again, you have this really difficult combination of low self-esteem, needing that validation and reassurance from others, while at the same time not being able to maintain those relationships with others because of the borderline tendencies, and becomes hostile and aggressive, and because of the fear of abandonment and all of that. And so this combination is just suggests a lot of difficulties, and I'm sure was used to help explain some of the things that Amber Heard allegedly did to Johnny Depp in through this legal process, things that have been heard, things that we will not talk about on the podcast.
Right.
But that those diagnoses help to explain why we saw some of those behaviors.
Right. You mentioned earlier that borderline and histrionic personality disorders typically are made with women, whereas antisocial and narcissistic made with men. And the histrionic personality disorder, wanting to be the center of attention, brings to mind one man who might have had histrionic personality disorder. That was Theodore Roosevelt. And his daughter once said about him, he had to be the baby at every christening, the bride at every wedding, and the corpse at every funeral. He wanted to be the center of attention. And there, I guess one of the, I don't know, History Channel or something is going to do a special on Theodore Roosevelt. That's one of the things they're going to talk about. And in one of the scenes, he steps off a train and throws his arms in the air and very dramatically says, "Here I am." And so that's sort of, come and attend to me.
Yeah.
And so Roosevelt may be one of those men. And I also discovered that he is an AMAB, assigned male at birth, not to be confused with AFAB, assigned female. So he's an assigned male at birth who might, I don't know because I never saw him as a patient, but he has some of the characteristics of histrionic personality disorder.
Right. And yeah, so again, we kind of talked about some of the characteristics of histrionic, but like I said before, this with histrionic, you tend to see extreme anxiety and depression, and those symptoms drive that need for reassurance and everything from other people. The emotions seem, at least to others, oftentimes to shift a little bit and to be pretty shallow, because they will change. if they're given lots of attention and lots of focus, then everything is great. If they're not, then they got to do something to, and sometimes that may be a temper tantrum or something, but they'll do something. But this is also where you see, sometimes people will associate histrionics with the way people dress.
That's right.
If a person is dressing in a way to garner a lot of attention, it's subjective, of course, because a person can dress however they want to dress. But if a person is dressing with the goal of, I want to get attention from other people, so I'm going to wear these kinds of clothes, or I'm going to wear, dress this way, that is something that sometimes you see with a person who's histrionic.
Right. We talked earlier about making these diagnoses in teenagers, and you bring up an excellent point. Many teenagers will dress in a flamboyant way. They will dye their hair. They will cut their hair into strange structure, sculptures, of hair and of makeup and of clothes. But teenagers are by nature attention seeking. They want that attention. And so that sort of behavior in a teenager, we would consider normal. That's a cultural expectation. They're just doing what teenagers do. But if you're 35 or 40 and you work at IBM, you don't have a mohawk and body piercings and tattoos on your neck, because that exceeds cultural expectations. Okay, so that's why it's tricky to make these diagnoses in adolescence, because many adolescents have erratic behavior. They have erratic relationships. They have rapid mood swings. And those are a normal part of being an adolescent. So we have to be careful about making these diagnoses in teenagers.
Absolutely. And so wrapping up about histrionic personality disorder, you get someone, you may have a person who is, looking for that attention. So that could lead to being overly flirtatious and very charming. And, they get a little too comfortable with people a little too fast. Again, seeking that reassurance, that encouragement. And so when you have, kind of bringing these together, is if you have these diagnoses, and you experience these types of behaviors, and you're, again, you don't necessarily know that it's any different than anybody else behaves, then you will do things that very clearly other people are having a problem with, but you don't even necessarily understand why the person is having a problem with it. Right. Richard, you and I, we talked to a person one time who, she was engaging in some very erratic behavior, making some very unusual decisions. And at the time, she thought they were perfectly fine. Of course, this makes perfect sense. Why wouldn't I do this? Once removed from the situation, you sit down and you say, let's talk about this. What do you think the other person might have seen or might have thought when you were doing this? You say, oh, okay, maybe that wasn't such a good idea. Maybe I shouldn't have done that. But it's really difficult to get the person to that point to where they can work through that, because it requires a lot of introspection, a lot of insight.
Right. Yeah, and these are people struggling with relationships, and they have to understand that it is their thinking and behavior and emotions that are creating these interpersonal problems. So if they don't want to have these interpersonal problems, then they have to address those three things in the therapeutic setting. Right.
And they tend to think that those problems are caused by the other person.
Yeah, exactly. So it's not anything I'm doing. It's always the other that's creating the problem.
Right.
Now, the last thing we want to talk about is, along with these diagnoses came another headline. And the headline was, "Debunked psychological diagnoses of Amber Heard must be discounted, a prominent psychologist warns." And I thought, oh, this is interesting. So these are debunked. Now we have these diagnoses, and this person is saying we shouldn't even pay attention to these. And I thought, well, why not? What's the deal here? And the deal is that there was an article published in The Independent based on an interview with Jessica Taylor. She's a PhD. She was a senior lecturer in forensic and criminological psychology at the University of Derby. So she's from the UK, probably followed the UK trial in 2020. So I'm sure she was involved in some way. But her area of expertise is the pathology, the pathologizing of women in mental health settings. In other words, we tend to pathologize what might be normal female behavior, and it shouldn't be pathologized. And that's her, I don't want to say axe to grind, that's her perspective, is that these kinds of diagnoses are usually applied to women, and perhaps we should rethink the application or even pathologizing these kinds of behaviors, especially when they're applied to women.
Right. So her concern is with the two diagnoses, borderline and narcissistic, or I'm sorry, borderline and histrionic personality disorders. We see this though in lots of disorders.
That's right.
ADHD is primarily diagnosed in boys. As we said before, antisocial and narcissistic is more often diagnosed in males. Depression is more often diagnosed in females. So we see that, but this Dr. Taylor is concerned about the overpathologizing of women, and she kind of pulls from history a little bit, because again, if we're honest, that has happened in the past where women have been much more likely to be diagnosed with certain things, especially things related to emotional regulation and emotional expression. And they've been much more likely over the years to be diagnosed with these disorders than men.
That's right. Two of the complaints that her primary complaints are that, and I'm quoting here, that these are not proven medical conditions. That was one of the things she said. And also, they're highly contested and controversial labels. Okay. Well, as you said, you can say that about many of these things. I don't know what she means by proven medical conditions, because is depression a proven, is anxiety a proven medical condition? I don't know what she means by proven. You don't prove these things. There are no lab tests, but there are no lab tests. There are no diagnostic tests for any of these, the DSM-4 labels, if you want to call them labels. We don't have tests for these things. They are all clinical diagnoses. They're clinical judgments that people make. So, but the larger issue is the gender bias that she talks about, because what the point that she's making is histrionic personality disorder was simply renaming hysteria. Right. And hysteria was a diagnosis used exclusively with women. It comes from hysterectomy. And so it's a diagnosis made reserved exclusively for women in the initial version of the Diagnostic and Statistical Manual. And she said it was simply a name change to histrionic personality disorder, but it tried to capture the same gender. It was still pandering to the same gender bias.
Right. Yeah. And I think that it's difficult because, you certainly appreciate, I certainly appreciate what she's saying. And I think to a large extent, you can see how that's happened. You can see that that's true. And in a lot of ways, in a lot of settings, it's very true. I think that one challenge to it, though, is what we began this whole discussion with, and that is, we're not just talking about the presence of these behaviors. Right. We're talking about the presence of these behaviors within the context of causing a lot of problems and impairment in functioning, dysfunction and distress caused by these symptoms. Just because a person, just because a man or a woman, it doesn't necessarily matter which, has some of these characteristics, wants a lot of attention and wants to, sort of thrives off of other people that way. Just because a person has those symptoms doesn't mean that they have histrionic personality disorder. It just means that's part of who they are. It's not a personality disorder until it meets those impairment criteria. And that, I think, differentiates it. Again, I think it's a very valid point that clinicians sometimes make these diagnoses without fully considering those other aspects of the diagnoses.
Right.
Absolutely. I completely agree with that. And we, for that reason, we see a lot of overdiagnosis of a lot of different things. Just because a boy misbehaves in class doesn't mean he has ADHD.
That's right.
So there's lots of people who have some of these characteristics who aren't necessarily really suffering from or experiencing a personality disorder, but they may get that diagnosis. And so I appreciate that from the overdiagnosis perspective.
Right. And just because a person meets criteria, diagnostic criteria for a disorder, if there's no impairment, you don't make the diagnosis. I mean, and we know that about these things. But so the question in this trial is there some impairment? You know, and that's what they're going. And so one psychologist is saying, yes, there's impairment, and these are the reasons. And the other psychologist might be saying, no, there is no impairment. Right. Or maybe she's saying these diagnoses aren't appropriate, but the issue comes down to impairment.
Right. And I think that that's the big thing that has to be considered. There's this thing called the Goldwater.
The Goldwater rule.
The Goldwater rule. And that is that from a mental health perspective, at least, psychologists, psychiatrists, we're not supposed to make a diagnosis of someone that we haven't evaluated.
Right.
And so, sure, you know, the Dr. Taylor may have a problem with those diagnoses and the frequency with which they're made and with whom they're made. But that doesn't necessarily, and I don't know that it should necessarily be discounted, because, you know, Amanda Heard was diagnosed with him after someone spent 16 hours with her doing a thorough evaluation. That person spent time and did the evaluation of Ms. Heard. Dr. Taylor didn't. And so, you know, yes, I think it's very important and critical that we question diagnoses and that we make sure that diagnoses are made with integrity and are made appropriately, and with adequate information and experience. But just because diagnoses are misused doesn't mean that we should completely discount what they're representing. If
that's right. And Taylor is not, I don't think she's speaking to, does Amber Heard have some problem? Does she have some impairment? She's taking issue with the classification system. And what she's saying is there's something wrong with the classification system. She's not talking about, but you're right. If you don't see a person, I remember when Donald Trump was elected president, there was this flurry of, is he a narcissist, or does he have some, and in our field, we agreed back in the 60s that we wouldn't make a diagnosis unless we did the examination ourselves, which is I think probably a good thing. You might think that a person has something, but you can't make a diagnosis unless you spend time with that person. Right. So that part's good. But we see the controversy with, and I think we could see this controversy with any DSM diagnosis. Right. I mean, certainly there are people who continue to think that ADHD is a myth, that it doesn't really exist. Right. And I think we could say that for any of the DSM diagnoses. Right. No, absolutely. I think that, you know, we're going to have to do a podcast, I think, very soon on the prevalence of autism spectrum disorder. I mean, if in my opinion, if you want to talk about a disorder that's overly diagnosed, you know, if you're thinking about true autism spectrum disorder, what are we at? Like 1 in 50, 1 in 52 kids or something? Yes, right. That would have. It's more than that. So that you know, we have to really question what we're talking about. You know, just because a kid is socially awkward doesn't mean that they meet criteria for autism spectrum disorder, but yet we see that. So a lot of our mental health diagnoses are overdiagnosed. A lot, and part of that is because poor clinician training or just insurance. You have to diagnose something to get reimbursed from insurance. There's lots of other reasons that it's happening. These two diagnoses, borderline personality disorder and narcissistic personality disorder, are overly diagnosed at times, especially overly diagnosed in women, and that needs to be addressed. But that doesn't necessarily mean that the disorders don't exist and that a particular person may not be experiencing those symptoms. I think you put your finger on the issue, it doesn't mean that they don't exist.
Right.
Okay? We need to be careful. We need to be thoughtful. But just because there is this history that is related to women doesn't mean that these disorders don't exist, because there are people struggling with these issues. They are struggling, significant struggles with relationships, and they need to be addressed.
Right.
Maybe these are the wrong names, but it doesn't nullify the diagnosis or the concern that we have for people who are struggling with these things.
Yeah. And just as a final quick example, I think we once talked about narcissistic personality disorder, and we talked about that there's two types of narcissistic personality disorder, and there's the one that is narcissistic but overly assertive, and but then there's another type of narcissistic personality disorder that's sort of a facade. They're narcissistic on the external, but they're very fragile. Right. That person probably should technically probably be diagnosed with narcissistic personality disorder and histrionic personality disorder, because they need that reassurance from other people, because without it, they crumble. As soon as something doesn't work out the way that they need it to, or somebody doesn't give them the attention or accolade that they need, they crumble and fall apart. Well, that's what we're talking about with histrionic personality disorder.
Yeah, and so you see the relationship between histrionic and dependent.
Right.
There's I didn't get what I wanted and I fall apart.
Right.
Right.
Absolutely.
So I do whatever I have to do to get it back.
Right.
So yes, there's overlap and interaction, but I don't think it negates the existence of such things. Right.
You just have to get better at making.
You have to be good at what you do. That's right. That's the important issue here. So when we talk about personality disorders, we make these diagnoses, 1 of 10. We said there are 10 personality disorders. When a person's thoughts, emotions, or behavior exceeds social norms and is present across time. It's not occasional. It's who you are as a person. It's how we think about ourselves and others. It's how we respond emotionally. Mm-hmm. It's how we relate to other people, and how we control our own behavior. So there's these 4 issues. Okay.
Yeah, absolutely.
And the other thing is, people often ask, there are no medications for these. These are characterological disorders. And so there's no medication for this. If a person has a volatile temper, if they have anger outbursts, you could medicate an anger outburst. You can't medicate a personality disorder. It is who the person is, and you can't change a personality with medication.
Absolutely.
Nevertheless, there are treatments, but those treatments begin if the person acknowledges that there's a problem. That's where the treatment begins.
Right. Yeah.
This brings me to our friend Sigmund Freud. His birthday is this week.
Yeah.
Yeah, May 6th. He was born May 6th, 1856. So what is that, Friday?
Yes.
Friday?
Yeah.
May 6th is Friday. Yeah. So that's birthday of Sigmund Freud. And Freud he famously said, the only person he couldn't treat was a narcissist. And he said, because for a narcissist, there's nothing wrong with me.
Right.
Okay. So if you begin with that there's nothing wrong with me, then you can't change anything.
Absolutely. So yeah, these clinical diagnoses require clinical treatment, and that clinical treatment can only begin when there's some awareness, some insight that there's something that needs to be treated.
Yes. Somebody has to come in and says, I think I have a problem, and that's the beginning of the process.
Absolutely. All right. Well, that's it for today. Until next time, stay happy, stay healthy, and forget to be afraid.